So the top left figure shows a typical clinical pathway for the radiotherapy. So we see that after the patient diagnosis, before patient receives the radiotherapy treatment, there is a preparing step. In these preparing steps, two major sub-steps are here. So one is the radiation oncologist or the physicist will target often manually or semi-automatically will segment those tumor target volumes and those organ risks. Then, based on these contours, the physicist will conduct the dose optimization and planning. So, depending how long this preparing step takes, normally days to weeks, then the patient will eventually come to receive the radiotherapy treatment. So for the preparing step, so this target volumes and organ risk segmentation part is a step that requires a huge amount of experts' time and energy. So often, like for one patient, it takes more than 3 hours to finish all the target volumes and OAR segmentations. And also, there exists a pretty high inter or even intra-observer variability because of the experience of the physicians, and also because of the availability of the imaging modalities or other information. So here in this step, there is a tremendous need for the AI technology to play a big role to increase the accuracy and to standardize the quality for this step. So there are four major tasks in this step. So one is the organ risk segmentation. So organ risk refers to the healthy organs. They are in charge of our normal functions. So these regions try to avoiding the excessive radiation exposure. And the second one is called the gross tumor volume, or GTV. The GTV are the primary tumors visible from the imaging. It's kind of like the macro level tumor range. And the next part is the metastasis lymph nodes or lymph node station. These parts are because we know that the cancers often spread through the lymphomatic systems. So these parts are affected, those refer to those lymph nodes or stations affected by the cancer cells. And finally is called the clinical target volumes, the CTV. CTV are the region that covers not only the primary tumors, but also the possible spread of the cancer cells. It's kind of like including the microscopic level expansion. So we see that in all these four tasks, there are many parts that the machine learning, deep learning, material image analysis can help a lot. And finally, there's also another one need is the multimodality imaging registration, because often when you, for example, you segment the tumors, not only the CT image is available, but also the contrast CTs, MRI PET, those will be very much helpful. So we need to fuse these images and do a better segmentation job. So the GTV, the metastasis lymph node, and the CTV, those part needs to receive the high radiation doses to sufficiently kill the cancer cells. Okay, so in this talk, I will talk about majorly three sections. So the first is the head and neck organ risk segmentation. That's in the head and neck area. The second section is focused on the chest part. We'll talk about the chest organ and the chest lymph node station segmentation parsing, and the metastasis lymph node segmentation and detection. And the third part, I'll talk about some target volume segmentation in the esophageal cancer, the gross tumor volume, GTV, the clinical target volumes. And I'll also briefly mention one deformable image registration recently proposed that seems to have a very good performance suitable for the tasks. So by reviewing all these recent works, we found that many of the works try to emulating the physician's reasoning process. This can this can boost the accuracy and increase the robustness of the models. And meanwhile, many of the works have conducted the multi-center large-scale validation, which is really necessary to demonstrate its clinical applicabilities. And these are the papers that are related in this talk. So the first part is the organ at risk in head and neck regions, and the other part is the gross tumor volume, the GTV segmentation in esophageal cancers, and the third part and the next part is the lymph node station and lymph node segmentation detection, and finally is the clinical target volumes segmentation, and also we'll mention the image registration here. Now let's first take a look at the organ at risk segmentation in the head and neck region. So there are a lot of healthy organs existed in our head and neck area. They are in charge of our normal life, the quality of our normal life, like the parotid, like the vision, like the smelling, the hearing, all these things. So those healthy organs needs to be accurately contoured to avoid the radiation exposures. So there are like normally over like 40 those organ risks densely distributed in this area. So this makes the organ risk segmentation in head and neck area extremely time consuming and difficult. So normally it will take at least 2 hours for the physician to finish contouring or segment one patient's head and neck organ risk. And there are also a large anatomic shape variance, size variance, and contrast variance within these organ risks. So the right part shows some 3D rendering of the organ risks, and as well as the 2D figures. So, and often the physicians often needs to refer to some other imaging modalities to better handle this segmentation problem. So some of the previous work will segment like 20 or near 30 organ risks. So one of the recent works in CVPR 2020 tried to segment 42 organ risks. This is the most comprehensive data set so far. And this 42 organ risk is also consistent with the international head and neck organ risk delineation guideline recommendations. So we'll focus on this work first. So segmenting a large number of the organ risk in this densely distributed area is not an easy task. So this work they propose to using the stratified learning to solve this problem. So they basically they use the organ level stratification and the neural architecture stratification to solve this problem. Let's take a close look at it. So they first divided these 42 organs into 3 different levels according to their segmentation difficulties. And so first, so they selected some anchor organs which have the reasonable size and often with clear boundaries. Those are easy to segment. And then they separate another level of the small and hard organ risk. Those refers to the organs that have the extremely small size, and some of them are hard to locate, or have the complex shapes, or have the intensity contrast that very poor to the adjacent structures. So these are the small hard levels, and the rest of them it refers to the middle level organs. So by doing this process stratification, so more flexible segmentation pipelines can be designed for the different groups, and also like they can use the anchor groups to help guide the segmentation of the middle level and the small hard, those more difficult groups. So So for example, they first segment the anchor organs and then use the anchor priors. They will help segment the middle levels. And for the small and hard group, they design a detection then segmentation pipeline. So there'll be, because those organs are pretty much small. First, you directly segment from a large volume. Will need to handle the extreme imbalance for the foreground and background objects. So using the detection and segmentation pipeline, it'll be much easier to achieve an accurate segmentation task by first roughly locating where they are, and then you segment it. And the next stratification is along the network architecture. So because the different characteristics of these three organ groups, so intuitively we'll think probably different network architecture will be optimal for different categories. So they conducted a neural architecture search for each organ groups to provide optimal result performance for each group. So they use they search between the 2D, 3D, and the pseudo 3D convolutional kernels with different kernel sizes, 3 by 3 by 3 or 5 by 5, and these are the searched the convolutional blocks architectures. So actually, it's pretty interesting. We can see that for the anchor branch, and also many of the middle level branches. So actually, a mix of 2D or pseudo 3D, the mix of 2D or pseudo 3D kernels dominate those two branches. However, for the small and hard branches, more 3D kernels will be used. So this is kind of like consistent with our human intuitions. So this shows some ablation results from the previous methods, like indicating each step's effectiveness, like the process stratification and the network stratification. We can see that the anchor organs have a very not a big performance improvement, because of anchors are already easy to segment. However, the middle level and the small hard level, we observe a significant performance improvement. Here are some quality examples. And there's also a comparison with a previous leading approach called UANet, which is published in the Nature Machine Intelligence in 2019. So they demonstrated almost a 5% absolute dice improvement, and probably close to 40% average surface distance reduction. So based on the previous methods, the authors further conducted a multi-center evaluation for this work. They used the trained models to directly test it on the more than 1,000 patients from 6 centers. Besides that, they also conducted a pretty comprehensive multi-user studies, including the contouring accuracy comparison and even the downstream task, the dosimetric accuracy comparison. So this work is currently under review in the Nature Communication. So let's take a look at the segmentation performance when generalized to the external centers. So here listed the 13 organ risks, both existed in the internal hospitals and one of the external hospitals. So here are the results. We see that although the DICE score overall have about 3% decrease, actually the surface distance and many of the organs, there is not an obvious performance drop. So some of the drop, when you look at the results, you see that it's more of like the different annotation styles in different hospitals. Although when we selected the patients and curated the data set, they have already been edited by the physicians, but there's still some degree of variation existed. And the bottom table shows the comparison of the UANet with the proposed method called source in the 5 external centers. We see that the source can consistently improve the UANet by 3 to 5% in dice score and about 20 to 40% in the distance error reduction. So there's also a comparison between the inter-user variation on the segmentation accuracy with the source and the source revised model. The source revised model refers to the senior physicians will editate the source predictions and then compare with the ground truth contours. What's the performance looks like? So we see that the source and both source and source revised models, their overall performance is already like is smaller than the inter-user variation, which is about less than 80% dice score and almost like 8 millimeters in Harsdorff distance. However, the source and source revised, they have a substantially improved performance in like 8 out of 13 organs. And compare source and source revised, we didn't see a very clear performance difference, which indicates that the AI model, the source performance is already pretty much close to the senior physicians, or fits the physician's needs. So there's also another user study on evaluating the manual revision efforts. So that means there are senior physicians. They will examine each organs in the testing patients, and then they will estimate the editing efforts for these organs, like no revision, or if we need like less than 1 minute revision, or 1 to 3 minutes revision, or larger than 3 minutes revision. So we see that like almost 98% of the organ risks, they only require either no revision or less than 1 minute revision. So only 2% needs the 1 to 3 minutes revision. So no organ risk needs more than 3 minutes revision. So this can further demonstrate the clinical usefulness of the source model, and for the timing saved by the physicians, we see that the manual delineation will require more than 100 minutes, while editing on the source results, it have like 90% time reduction. So next is a user study on the dosimetric accuracy. So not only they evaluated how the segmentation accuracy is, they further examine what the contours or segmented results will bring when you overlap on the dose maps of the existing plans. So we follow the mean dose differences and max dose difference in the Red Journal works and compare those dose accuracy from the source model and the source revised results and the human reader. The results are shown in this table, summarized here. So as we can see that both the max dose difference and the mean dose difference, the source or source revised model has a less dose errors as compared with the human reader, which represent the inter-user variations brought to the dose matrix. This middle row figure shows the DHV figures for some organs, and the bottom part shows the scatter plot of this mean dose and max dose distributions from the 3 groups, the human reader and source revised. We see that the human reader has more like larger errors in some of the, or those larger errors outlier than the compared with source and source-supervised results. Yeah, so in short, we see that from this multi-center evaluation, the organ risk segmentation models, it really can save lots of physicians controlling times and standardize this process, and also can generalize well to the external data, and also leads to smaller dosimetric errors. So we believe this will be this will play a significant role in the future radiotherapy workflows for this task. So next, let's move to the thoracic region to talk about the chest organ and the lymph node station segmentation first. Then we talk about the lymph node detection and segmentation. Because the lymph node station segmentation, some of the ideas is similar to the previous head and neck organ risk segmentation. So for lymph node station, if you are not familiar with it, so those are a group of lymph nodes that form at the same anatomic regions. So for the chest, for the the mediastinal regions, there are normally like 14 stations, defined by the experts, and those stations can help understand the cancer spread pathways, and also those lymph nodes and the lymph node stations will determine the treatment selections. For example, the left bottom figure shows a axial view where there's a lymph node in here in the inside the circle, and first the physician need to decide if it's a malignant lymph node. If it is, does it belong to the station 7 or station 10? Because different stations, the treatment are completely different. If they belong to the station 10, so that's the same side of the tumor, so surgery will be recommended. But if it belongs to the station 7, the chemo and the radiotherapy treatment will be recommended. So this lymph node stations is very helpful for this treatment selection, and also the lymph node station will be helpful to determine the later on we will talk about the clinical target volume regions. Yeah, it will be helpful to determine the CTV areas because it covers the cancer spread ranges. So this is based on work published in 2021 MICCAI. So the lymph node station actually, this is a pretty has a strong domain knowledge, and this is defined by the experts. The lymph node station boundaries are related with lots of anatomic organs. It's highly spatial context dependent. However, so for the chest region, for the lung cancer, they use the definition of the IASLC. So however, so in the guidelines, lymph node station guidelines, these stations are described using the text description. So when you change the text definitions of this lymph node station to the precise 3D voxel-wise annotation, it's a very challenging task. So here they identified the 22 organs closely related to the lymph node station definitions. So they will first segment these 22 chest anatomic structures. And because these structures actually define the boundaries, define the borders of each stations, so they will segment these 22 organs first. And when doing this segmentation, similar ideas from the previous head and neck organ segmentation applied, because those are also lots of organs with easy and hard differentiation, different size, shapes, contrast. And then with this better stratified organ segmentation, they will try to determine the lymph node station boundaries. However, when you determine the lymph node station boundaries, there is a natural question: does all these 22 organs important for the computers to, or for the AI models to learn the station boundaries? Although those 22 organs are important, are all mentioned by the guideline, it may not be all of them are useful for the deep learning models to learn it, because there exists like the organ segmentation errors, because the more organs may lead to some overfitting problem, this kind of thing. So in this work, the authors, they conducted like the key organ search using the differentiable network search architecture. So which means after they gather 22 organs, they combine with the CT images, and then they conduct a key organ search like here to automatically determine which organs are important for the AI models to learn the station boundaries. And the results are pretty interesting. So here when we take a look at the DICE score and Harsdorff results for the top right figures, we see that when the searched key organs reach to 6, the performance actually comes to a plateau or stable regions. When more organs added, when it's larger than 12, 15, or 15, the performance actually begins to decrease. And those 6 organs like determined are listed here. So after we take a close look at it, we found that those are organs that easy to segment, has a stable performance, and also closely related to many station boundaries. So which is intuitive to what the human will interpret. And for this station segmentation results, so they observe like almost 20% absolute DICE score improvement when compared with a previous non-deep learning station segmentation method, because there are not lots of lymph node station segmentation works existed. Oh, by the way, when you use the 22 organs predictions to infer the lymph node station boundaries, we can see that although the DICE score didn't decrease a lot, but there are actually pretty large Harsdorff distance errors. Okay, so next we move to the metastasis lymph node detection and segmentation. So lymph nodes, so they are essential cancer biomarkers. The undertreatment will decrease the prognosis, and the overtreatment will affect the patient's life quality. And there are many works try to do the automatic detection and segmentation. However, this is a pretty much challenging work, especially when you consider the lymph nodes in the oncology area or in the radiotherapy context, because in radiotherapy, not only the enlarged lymph nodes are considered, the lymph nodes that have smaller size but may have a more close relationship with tumors will also need to be treated. So we refer to this the lymph node, the GTV lymph nodes. So so we take a look at, we use the esophageal cancer as an example. So for the esophageal cancer, there are studies demonstrate that actually the lymph node spread has some relationships with the location of the primary tumors. So how to model this relationship? So one simple way is that we simply divided the lymph nodes into 2 subcategories. One is the tumor proximal, one is the tumor distal. So because even when the physicians do this kind of GTV lymph node segmentation, they consider the distance relationship with the primary tumors. When the lymph nodes are close to the primary tumors, although there are not like an obvious metastasis sign in CT or in PET, they may be included. But for the distal far away lymph nodes, unless there is a clear like PET signals or the CT metastasis signs, the physicians will include those one as the GTV lymph nodes. So emulating physicians this reasoning process, this MICCAI 2020 work, they designed like a two decoding branch framework with the distance gating module to learn the lymph node segmentation for the esophageal cancer patients. because so one of the branch they focus on learn the features that related with the proximal lymph nodes, and the other decoding path focused on learning the distal lymph nodes features, and so by applying a distance gating function as output, so these models can be trained simultaneously. And the results are listed in the table. In short, so this distance stratification mechanism can improve the recall of the GTV lymph node segmentations. So they achieve an average mean recall of like 78%. So when the FROC is at 4, the recall is 73%, and this represents like 6% improvement for the mean recall compared with the previous work called Mulan, is a general lesion detection method. And when you compare with some binary gating method, there are also some percent of the improvement. So next, so the previous work is to segment the candidates of those those GTV LNs, GTV lymph nodes, and there's a follow-up work. So based on those candidates, they can further train a classifier to determine if this lymph node candidate is malignant or not. So this second step, there's a work in MICCAI 2020. They propose that when you do this second step, false positive reduction, not only the instance-wise lymph node visual features can be considered, but also you can consider the lymph nodes as a connected system, so that both the instance visual features and the connection, the relationship, the relationship can be modeled using the graph neural network on top of the CNNs. So they propose a CNN plus a GNN network to do this lymph node false positive reduction. So there is also some improvement observed in this work. So finally, we come to the third part, the final part. That's the GTV and CTV segmentation in the esophageal cancer and with the deformable image registration. So here's a little bit background. So the esophagus is a long range organs that has the large superior to inferior ranges. There are lots of essential organs adjacent to it, like lung, heart, spinal cord, livers, and the RT treatment is one of the core treatments for the locally advanced patients. So for the tumor or the GTV segmentation for the esophageal cancer, we see some examples listed here. Because the CTs in radiotherapy, we refer to the RT-CT or planning CT. So this CT often does not have contrast. We see that without contrast, actually the tumor boundaries is not easy to differentiate from these RT-CT images. So that's why so the previous works on even the esophagus segmentation or the esophageal tumor segmentation do not have a very high performance. So for the work that considered here, the authors recall that normally in the diagnosed stage, there's also a PET-CT scans available. So they try to combine this PET-CT with the RT-CT to improve the GTV segmentation performance. However, how to effectively utilize these two modalities is still it still needs to be explored, because the CT image has high spatial resolutions with the low contrast with the surrounding tissues. The PET imaging, that's the functional imaging modality. It can highlight the tumor activities, which has a high sensitivity for tumors. However, it also has low specificity. There will be false positive signals in the muscles or nearby lymph nodes or even hearts. And the PET also has the core spatial resolutions. So here, the left and right part show some examples where for the left part, the CT image has the poor contrast, while the PET has a reasonable characterized tumor regions. However, in some of the cases, CT has better visual features. However, the PET does not have a clear signals. So how to so they try to complement the strengths and weakness of these two modalities to develop esophageal CTV segmentation models. So here's the pipeline. This is a two-stream workflow. So one stream is only consider the CT imaging features. One model just learn the image features from the CT imaging and provide the predictions. And then after the registration of PET-CT and the RT-CT, the registered PET images can be combined with the RT-CT together and to feed to an early fusion model. So this model can learn like a mixture information from the PET and the CT images. And after get these two predictions, the CT predictions and the early fusion model, so a late fusion block can further refine some of the results to give a final GTV results once your PET and the CT are all available. And the one of the good thing for this framework is that for some hospitals, if the PET images are not available, the CT model alone can still provide a reasonable GTV results. And in this MICCAI 2019 work, so the PSN network structure is also proposed in this work. So there's one step that tries to register the PET to the RT-CT. For this step, when you directly register the PET to RT-CT, this is very challenging because PET and CT are different modalities. And they are completely different imaging modality. One is structure, one is functional. However, for the PET scans, there's often a PET CT, or we can call it diagnosed CT, available. So this CT is aligned with the PET. So then we can try to use this diagnosed CT to register to the RT-CT, and then use the deformation field to apply to the PET so that the PET and RT-CT can be aligned. So in their work, they first use a lung segmentation mask to determine the roughly same region between the diagnosed CT and RT-CT, because we see that the left top figures, the diagnosed CT has a pretty different, like the patient's poses and some of the imaging differences, like what soft bed or hard bed, this kind of differences. So the deformable registration require a good initialization position. So they use the lung to roughly align it. Then they use a fine transformation, then the deformable registration to register these two images. So for the deformable registration, the Ds is applied, which Ds represent the previous conventional state-of-art unsupervised registration methods. And here the bottom shows some examples of these registration results. So here I briefly mentioned that so one of the recent work in MICCAI 2021, they developed a deformable image registration using the self-supervised anatomic embedding. So this work is based on a novel work called SAM, the self-supervised anatomic embedding work that's published in TMI 2021. So the SAM can generate the dense semantic embeddings for each voxels. That's this embeddings describes its anatomic locations. This is a completely self-supervised approach, and it can provide the semantic correspondence between for each voxels between different images. For example, you have a template image here. So once you train the SAM, you select one point, and in the query images, it will automatically match to the most similar points with the semantic meanings in the query images. So this actually provides some very useful information for the registration process, because registration is often use a local image or some similarity features to align these images. However, for image registration, actually the semantic information is important, and the semantic information is not easy to be calculated in both conventional or nowadays the deep learning approaches. So here the SAM enhanced registration they call it the same, can enhance both the affine, coarse deform, and deform registration by providing more coherent correspondence. So some of the results are shown in the table. The green part are they demonstrate that even the SAM affine can outperform the elastic affine or the mind affine transformations. And with SAM enhanced features and the loss, it can have a clearly improvement over like a baseline voxelmorph deep registration methods. And also the performance is comparable or even better in some cases compared with the DEEDs, which is a very strong baseline. Okay, now let's go back to the esophageal tumor GTV segmentation. So here are some results. So when they cross-validated on the almost 140 patients, they demonstrated that both the early fusions and the PSN networks has some improvement over the previous, at that time, the previous leading methods. And they also compare with the other PET-CT co-segmentation method, especially the Kummer 2020. So this two-stream fusion works also has like a clear improvement on the dye score and the reduction on the average surface distances. And further, the authors conducted a multi-center evaluation using like 458 patients from 4 centers, and also conducted some user evaluations to compare with the inter-user variations and the time saving. So here are the quantitative evaluation results. So the institution 1 is the internal institution with unseen patients. So for these institutions, both CT and PET images existed. So when you directly do the testing, so the CT images, using only the CT images, they have a dye score of like 81%. And when it's enhanced by the PET, the dye score can be improved. And also know that there is unacceptable cases. These cases are where the models are almost completely segmented the wrong locations of the tumor, or just completely miss the tumors. So using the CT alone, there's almost 10% missed cases. However, adding PET, it can decrease to half of this completely missed patients. And when you take a look at the subgroup analysis, we see that the early stage T2 patients have a relatively low performance. This is also pretty much understandable, because for esophageal cancer, when it's at an early stage T1, T2, the tumors are still small in the mucosa layers, so those may not be very visible from the images. That's the internal evaluation. For the internal evaluation on the other 3 institutions, they see that they achieve an overall dye score of 79%, which is comparable to the internal evaluation. There's not a significant drop. And the other T stage and the tumor location subregion analysis shows similar results. They also conducted the comparison with other 4 doctors. So the short message is that they achieve comparable performance with other 4 doctors. And when the doctors edited on the AI's contours, two of the doctors, their performance can significantly improved. And the overall inter-user variation has been increased. The consistency, the inter-user consistency has been increased from 68% to the 81%, and the time reduction is 74%. Yeah, I know my time is, it's almost there. Similarly with the head and neck organ risk, also you do the manual revision degree analysis. It can be also seen that 76 to 88% patients need very minor editing in the clinical practice. The final one is the CTV segmentation. I'll very quickly go through it. So CTV is a region that covers the primary tumor, lymph node, cancer spread pathway. So it's kind of different from the tumor or organ segmentation, where you have a clear anatomic boundaries. So CTV is an area that's a kind of like a mixture of predefined and judgment-based margins. So previous work often used just as a image context to inference those CTV margins, which is clearly a U-post problem. So in this 2019 MICCAI, they propose a spatial context encoded model for this esophageal CTV segmentation, where they encode both the distant transforms of the tumors, lymph nodes, and some organ risk together with the CT image to inference the CTV boundaries. So here are some quantitative results. We see that there's a 10% absolute dice increase when compared using only the CT as an input. This clearly demonstrates the distant model's advantage. Here are some detailed analysis. Yeah, okay, so that's all. A brief summary. So precise radiotherapy in the modern era is in high demand because of the rapid growth of the aging population. And so right now, how to overcome the human observer variations and to alleviate the healthcare delivery inequalities is important. And in this talk, the 4 cornerstone problems have been described. And we see that they can be properly approached by incorporating many key clinical insights into the methodology designs. And also the multi-center evaluation is helpful to fully validate the performance in the clinical practice settings. And hopefully this can encourage more collective and multidisciplinary precision workflows to happen in the future. Yeah, that's all. Thank you very much. I'll be very happy to take any questions.
Thank you, Dakai. A wonderful talk. So we have a few questions from Q&A. A question from Yading Yuan. This is a great talk. For those metric accuracy on head and neck, did you redesign those plans based on the auto segmentation results? Thanks.
Oh yeah, that's an excellent question. I think in the papers they publish in the papers on the archive currently under reviewing. In that paper, they didn't redesign those plans. They directly overlay the predicted OAR contours on the original gold plans and see those differences. However, I know that they further conducted some those plans where they have redesigned those plans, and then using the redesigned those plans, and those redesigned those plans are based on the predicted OAR contours, and based on those redesigned those plans, they further calculated the dose metrics, and I think similar observations are found with this redesigned plan doses. Yeah, thank you. That's a very excellent question.
Yeah, thanks. So a second question from attendee. Could you talk a little about the organization of the multi-center studies? How are they organized? And how are the data protection regulations handled?
That's a good question too. I think this we have to give credit to our collaborated physicians. So once we determine that we want to conduct the multi-center studies, we have a target. We have, for example, we evaluate the tumor segmentation results. So the physicians, they our collaborative physicians, they try to organize these different suitable centers, collected those data. They communicate with the physicians in different hospitals, and collected the data based on our predefined some patient selection rules, and they curated the data. Then we'll evaluate it. Yeah. So there are lots of work done by the physicians.
Yes, thank you. Another question from Dr. Hao Chen. Excellent talk. Can you comment on the quality control of ground truth on contours and dosimetry, since this is quite important for evaluation?
Oh yeah, that's another excellent question. Yeah, very come to the point. Yeah, from our experience, this the quality control takes a lot of time for the large center, for the multi-center large scale evaluation. So normally we will form a center group of physicians, for example, 2 or 3 physicians. Those 2 or 3 physicians, they are the most, we consider they are the most experienced physician in certain tasks, and they will examine all the annotations from the different centers, and if they find some inconsistency, they will let the physicians in different centers know, and before that we try to have first for different tasks we try to have a guideline for the segmentation. For example, those head and neck organ risks or the esophageal tumors, we try to have the guidelines. We make sure that we make sure the physicians in each institutions, they either follow these guidelines in their daily practice or they are very familiar with that, so that these curation steps can be sort of smooth. Yeah.
Thank you. So more question from Dr. Hao Chen. So another question is related to the status of AI models in radiotherapy. What's the status now in clinical practice? Have the AI model been integrated into the clinical workflow? Any challenge?
Oh yeah, that's a very practical question. So I think right now we are at the edge of because after the methodology development, the large scale evaluation, we are now at the edge of reintegrating this into the clinical practice. So the radiotherapy has its own. It's a pretty special domain because they need although your segmentation model can be accurate in many cases, they need the physician's interaction. So normally when you integrate it into the clinical practice, you have to do this through the existing radiotherapy software delivering companies, like the radiotherapists, some hardware companies. They also have the softwares. You have to collaborate with them and deliver them. Or there are also some companies that they only work on the software part of the radiotherapy. You have to collaborate with them and integrate the model into them. So far, I think this is in the process of the integration. Yeah, there are challenges like the running time or how you handle the sometimes there are corner cases coming, the speed and the memory, the GPU's memory, the CPU's memories concern, all these kind of things. Those engineering things has to be taken care to have a better feeling for the physicians when they really use it in the clinical practice.
Yeah, thank you. I think we are just about the time, and thank you for the wonderful talk and thank you for the wonderful questions. Thank you all. The recorded video will be available if Dakai allows that. We will put the video on our MICCAI YouTube channel. Yeah, that's it. Thank you.
Yeah, thank you, Sam. Yeah, thank you, everyone.
Thank you, everyone.
Bye.
Bye.